All right, thank you, Ali. I'd like to thank SAGES for the privilege of the podium and the session coordinators for the invitation. I'm sort of fighting a losing battle here from the get-go, but forewarned is forearmed, so this is where I live and work. These are my disclosures. There's very few people in the audience, but I always say when I show my disclosures, if anybody else wants me on the payroll, see me after the operation. About conversions, relationships, jobs, life, etc., one of the hardest decisions you'll ever face in life is choosing whether to walk away or try harder. And this is an interesting and a much more philosophical debate than I thought I would give, merely because there's an incredible lack of data on conversions and reasons for conversions. And I think when you look at conversions in general surgery, you have to talk about conversions that are related to access, and then generally from the GI hernia perspective. So we do have multiple operations that we do, and I just selected these partly in random, but mostly because the two top operations, cholecystectomy and incisional hernias, are the high frequency operations. Foregut and bariatrics is what I do, and colorectal has been discussed extensively. And I think it's interesting that the learning curve for the colorectal surgeons has sort of gone from general surgeons about 5 years later. The real disclosure is I do minimal invasive surgery. I actually took this picture because my brother-in-law is a contractor and I wanted to show him that I too have big drills in my operating room. But I'm privileged to do minimal invasive surgery in a facility and an operating room where I have very, very good help. So full disclosure is I've been doing laparoscopic surgery basically before some of the people here actually went to medical school. And I used to think that once you get to about 10 trocars is when you start to consider operations to open surgeries. I've also trained minimal invasive surgery fellows for almost 20 years. But most importantly, when it's hard laparoscopically, it's usually that not really easy open. And when you're preparing this kind of conversation or discussion, what I like to do is I like to look at who's going to follow me and what they're talking about. And so I looked at this little article written not only by the senior authors or session chair, but Dr. Varlan is actually the third author. And this is an article out of Harvard where over the period of from 2002 to 2009, they looked at about 1,100 or 1,200 cases. And they tried to analyze exactly why they were converting for laparoscopic cholecystectomies. And they looked at about 66 conversions. They took 4 right off the top, interestingly enough, because the surgeons tried to get into the abdomen and really didn't. And I think that right there is a flaw in this paper because sometimes if you really have difficult access, conversion is just laparoscopic. It's just not possible in all cases. They looked at why surgeons converted and basically gave them category codes below and showed that about in 49 or almost half the cases, the surgeons really didn't give it the good old college try or the real old Harvard try and converted expeditiously. Nonetheless, their conclusion in the discussion is once the appropriate number of ports is placed, and they defined a good old college try in laparoscopic cholecystectomy as placing 4 ports or more, surgeons should use judgment as to when to convert, and they acknowledge that conversion can be a sign of good surgical judgment, provided a genuine effort on the laparoscopic approach has been made. Interesting. If you look at poster 65 here, and that's at this conversion. Incidentally, that previous paper was presented at San Antonio and SAGES in 2011 as an oral presentation, and this is a poster 65, which is presented here, talking about advanced training and conversion. And at Cornell, in 3 years, we looked at about 1,400 patients. Dr. Afani is a chief resident and future fellow who's going to, he presented this poster. Of the 1,400 patients, 600 were deemed acute cholecystitis. And what we actually wanted to look at in this paper, or this poster, was 3 surgeons who were fellowship trained, and we'll define them as fellows, and 6 surgeons with lots of experience. The conversion rates for the fellowship-trained surgeons was less than 2%. The lots of experience didn't really pan out because their conversion rates were actually higher. So although we can define it by, we're actually just talking about acute cholecystitis now, you can define it as surgeon-based, or you can define it as pathology-based. But when you take the whole factors out of the equation, the bottom line is a good training beats good experience. So there is no substitute for bad training. I have some comments on access and conversions. You need the appropriate ancillary equipment. In order to attain access, you need to have more than one arrow in your quiver. And you can use the Varus and the Palmer's point. Optical trocars are also equivalent. And using a Hassan technique and being able to dissect in a small hole and bring things forward and do the fascia under direct technique. Longer instruments are often an advantageous, especially in obese patients, obviously. Bed positioning, and obesity is usually not a contraindication for laparoscopy, but as I mentioned before, sometimes you know right away it's just not worth it. And getting in, if getting in is too much of a problem and can create problems. There's some myth about bariatric surgeons. We do not enjoy performing all types of general surgical procedures on the morbidly obese. But the biggest myth is if you don't perform bariatric surgeons, you won't have to operate on morbidly obese patients. It's probably a bit hard to see, but the United States leads the world in many things, but approximately 1/3 of your patients will now have a body mass index of over 30. And to all kudos to our colleague in Greece, but you ain't seen nothing yet. So many and a lot of general surgery patients are overweight or obese, and many operations are done laparoscopically, but not all operations. And I think this is the sort of kudos to our colleagues, and it was mentioned in the previous talk, that this sort of truncal obesity makes operations in the pelvis much more difficult than foregut operations. So comments on some other operations. I think the foregut is easier laparoscopically, especially when you place your patient in steep reverse Trendelenburg and get the liver out of the way. You can see the hiatus very clearly. There are some tricks. But the caveat on this is redo operations and going in, especially on sleeve leaks that have had developed abscesses and going down, it's not even worth it to try this laparoscopically anymore. Incisional hernias, we're talking a little bit about laparoscopy, and although I was a fervent for doing these operations laparoscopically, more and more are there combined operations and part open operations as the functional results of the purely laparoscopic approach are less than satisfactory. Bariatrics is probably easier laparoscopically. Every time I finish a case or I have to convert a big patient open, I think the forefathers of the bariatric group who did this open for years, again, liver retraction, hiatal. There's lots of tricks that you can use in bariatrics to go, and that's sort of beyond the scope of the talk here. And I think colorectal is interesting because in spite of over 10 years now of pretty significant talks at SAGES and other meetings, the penetration for open versus laparoscopic colorectal surgery is not. So if this operation is so much better, and why aren't more surgeons doing it? And I think the answer is the pelvis can be really, really difficult. Nobody's going to argue that a right colectomy is probably an easier operation, but getting down there, especially if you've got a significant amount of inflammation, or as a previous speaker mentioned, a large tumor. So the bottom line is, because there's so little data, let's just talk about cholecystectomy for a moment. Conversion is bad, and essentially it's all about money. When you combine the laparoscopic OR costs with a conversion hospitalization length of stay and obviously the patient quality of life, it's all about dollars. And so the data that I think my colleague is going to present after is that you can persist and get it done. And I think that's maybe an error. It might have been right about 5 or 6 years ago when you were earlier in your learning curve, but probably the longer you persist, the more you can get into trouble. I'm not really that smart, but this guy was. And he said insanity is doing the same thing over and over and expecting different results. And I think if you look at what's out there from the medical legal point of view and We all don't like lawyers that represent patients who sue us. This is an article out of Archives that was actually cited in the previous article. Tom McLean looked at a group of, I think it's in Kansas City, but it's a group of 120 odd litigations by laparoscopic cholecystectomy over a period of time. And actually, of those 122 patients, there were actually 15 where the operations had been converted. What's interesting on this data is if you look at it, when you got a plaintiff's outcome, in other words, the patient sued the doctor and won, the indication for conversion was on the surgeon's discretion 40% of the time, but at 60% of the time, the conversion was because there was a recognized injury. So these surgeons persisted, created an injury, and the average payout was just shy of $600,000. When surgeons won, about 60% was exactly flipped. 60% of the time, the surgeon said, whoops, it's tough, I'm getting into problems, I'm going to convert, I need to convert. So there's some data there that shows persistence, actually, in the face of adversity, is probably a strike. And this is probably, I'm going to go back, that you should probably look this article up. There's some interesting philosophical discussions that are past the point of the talk here, but about how patients actually decide to sue it. And he uses a baseball analogy of strike one, strike two, and strike three. And often patients forget that you told them that you can do this operation open and you might need to convert, and they consume that you're not good and you converted. Long operations, especially OR time, I'm going to arbitrarily define a long operation as over 3 hours. With high BMIs and patients with diabetes especially, convert you. So persisting in the face of adversity, taking a long time to do an operation where you shouldn't do, creates these problems. In obese patients, you get crush syndrome or rhabdomyolysis. Definitely in bariatrics, you have a higher rate of pulmonary complications with longer operations. And of course, even with heparin, you get a higher incidence of DVTs and associated PEs with long operations. So what I've learned about conversions and trying to minimize conversion is you've got to be there for the takeoff unless you're really part of a big team. In other words, you have to be there to position your patient's padding and straps. Because if your patient, you're going to work in an unfamiliar and uncomfortable environment, you want to have that done. There's always room for another 5mm trocar, in spite of all our friends with notes and sills and whatever. Of course, you've seen the penetration of that over the last years, less and less and less. There's always room for another 5mm trocar. The patient will not know if you repositioned a trocar. And in obese patients, it's not about the fulcrum or the leverage, it's actually about the angle you put your trocars in. It's the last thing fellows have to learn when they're doing advanced laparoscopic is how to position. It does not matter what your trocar looks like outside, it's the angle. I think when you get into a tough case, you put 2 insufflators on because then you can suction and use that operation just like a tough case then open. And some surgeries, including bariatric surgery, are easy laparoscopically, but there are some other types of surgeries on big people, but there's a time when a big incision is really not so bad. So to sum up, Warren Buffett made a few $1 billion, and he said that traditional wisdom can be long on tradition and short on wisdom. But I'm going to quote an article written actually by our president. And Jerry Freed said, ideally, the surgeon should wish to convert before any complication. It must be emphasized that conversion to open surgery should not be considered a failure or a complication. It should be considered a prudent maneuver for achieving the desired objective, namely safe removal of the gallbladder. So as I say to my young colleague, as the old lion looking down on the young lion, convert before you get into trouble. Thank you very much.